जी, अस्सलाम वालेकुम। अली कैसे हैं आप? अस्सलाम वालेकुम। अली कैसे हैं आप? अली आप मुझे को-होस्ट बना के बेशक आप इफ यू वांट टू लीव यू कैन लीव, नो प्रॉब्लम। अस्सलाम वालेकुम सरवत, कैसी हैं आप? थैंक यू वेरी मच। जी अल्हम्दुलिल्लाह मैं बिल्कुल ठीक हूँ। आप ही हैं ना सऊदीया से? चलिए माशाल्लाह, खुशी हुई क्योंकि आप काफ़ी पार्टिसिपेट करती हैं क्वेश्चंस में और आंसर्स में। अच्छी बात है, सबको पार्टिसिपेट करना चाहिए। बट यू आर रेगुलरली अटेंडिंग द लेक्चर्स, दैट्स वेरी गुड। जी जी, इंशाल्लाह इंशाल्लाह, अल्लाह खैर करेगा। जी, शेड्यूल से नो डाउट काफ़ी ज़्यादा फ़ायदा होता है क्योंकि खुद पढ़ना मुश्किल होता है एग्जैक्टली। या आवर स्पीकर टुडे डॉक्टर शमा इरफान इज़ देयर। अस्सलाम वालेकुम डॉक्टर शमा, हाउ आर यू? Dr. Sharma, you are the co-host now. Within next 9 minutes, we will start the lecture.
Okay, inshallah.
Inshallah. You can share your screen for your presentation.
Okay.
Because you are the co-host now, you can share it.
Okay. I'm going to share my. Okay. Can you see my screen, Dr. Anna?
Yes, yes, absolutely. I can see. Thank you very much for sharing, Dr. Shama.
Okay, thanks.
I hope that,
We
yeah.
still have 8 more minutes.
Yes.
So inshallah, I will start at 9 sharp.
Inshallah.
Sure.
What's the time in US, Dr. Shama?
It's now 8:52 a.m. morning time.
Morning.
Yes.
Good.
Yeah.
So exactly 12-hour difference with the Pakistan.
Yes.
Dr. Shama, I will just inform you, the lecture will be recorded. So I think so you don't have any issue?
No, I do not have. You can go ahead and record.
Okay, thank you very much.
ओके अगर मुझे प्रेजेंटेशन पे जाना है तो मैं यहाँ चली जाऊँ
प्रेजेंट का बटन क्लिक करें
और मुझे जूम पे जाना है तो मैं यहाँ चली जाऊँ कैसे जाऊँ
जूम पे जाना है तो
यहाँ
नहीं बंद कर
हाँ,
इसके स्टेप पे क्लिक कर इसको बल्कि बंद कर दो एक्स कर दो स्टेप
Hi, Dr. Ida, how are you?
Okay, so Assalamu alaikum, everyone. My name is, before we start, I will introduce myself. My name is Shama Irfan, and originally, as you guys know, that I'm from Karachi, Pakistan. I moved to US back in 2005, and once I moved here, I was working as a medicinal chemist for 4 years, and then originally I got my degree in chemistry, and after working 4 years as a medicinal chemist, I realized that okay, I have to go back to pharmacy school. I started my pharmacy school in 2009, and since 2014, I'm practicing as a pharmacist in US. I spent some of my time in Lexington, Kentucky. Then I moved to San Diego, California. I work at different places, like I work in the retail pharmacy, like big retail companies. If you have heard, like Rite Aid, CVS. I work a little bit for a hospital, and then for last 4 years, I'm working in a long-term care pharmacy that's called Guardian Pharmacy, or we call it formally as a Ron's Pharmacy Services. This is a long-term care pharmacy, and my area of expertise is geriatrics. So I spend most of my time in dealing with the older population. Uh, do you guys have any questions so far? Okay, so now, like today, I'm going to start presenting. My topic is like I'm going to talk about, I'm going to give you overview about psychiatric topic. In this general overview, I will discuss a little bit about schizophrenia, depression, bipolar disorder, anxiety, insomnia, substance use disorder, alcohol. Uh, in the substance use disorder, I am just going to talk a little bit about alcohol abuse, opioid dependence, and tobacco. So the first one I'm going to discuss is like schizophrenia. Schizophrenia is a chronic, severe, and disabling thoughts disorder that occur in 1% of population, and it regardless of uh, socioeconomic status, color, race, religion, it can happen to anyone. And in schizophrenia, if we are talking about DSM-5, so patient has to have 5 symptoms consistently for over 1 month. And if you are talking about those 5 symptoms, it has to be delusion, hallucination, disorganized speech, disorganized or catatonic behavior, and negative symptoms. So I'm going to tell you about what does I mean about delusion and hallucination. So basically, schizophrenia symptoms are categorized into 3 categories. First one is positive symptoms, um, then negative symptoms, and cognitive impairment. So if we talk about positive symptoms, we have to talk about delusions. In delusion, patients has false belief, like I would say in simple language that its belief is a god, or I'm a superman, or I have superpower. Then if we are talking about hallucination, then that's the perception of something that's not there. Those are the 2 main symptoms, and then movement disorder, thought disorder, we already talked about that. And if you're talking about negative symptoms is like difficulty beginning or maintaining activities, reduced pleasure for everyday activities that we called it anhedonia. And then allogia means the patient is not like willing to talk, is like absent. Social withdrawal, uncooperative attitude or behavior. And then cognitive impairments, it comes like may include like difficulty focusing or inability to pay attention, difficulty with memory, impairment, and verbal influences. So our main goal is to focus on treatment options that are available. So so there are two types of antipsychotic available on the market, and we categorize them as the atypical antipsychotic and typical antipsychotic. So atypical antipsychotics are effective for the treatment of positive symptoms. And for negative, atypical may or may not be effective for negative symptoms. So as I said, that antipsychotics are divided into two categories. First one is atypical antipsychotic. So those are the first generation or older antipsychotic. And the second one is, of course, the second category is second generation, called atypical or newer agents. And when we talk about first generation antipsychotic, so in general, when we talk about atypical antipsychotic, so those have so many side effects. Like, and if we talk about mechanism of action, I'm assuming that we already know about the mechanism of action of what is happening in schizophrenia. So it's mainly is a neurotransmitter dopamine disorder. And dopamine is categorized into 5, like it has 5 subunits, like D1 all the way to D5. And in schizophrenia, we mainly focus on D2 receptors. And then in general, first generation antipsychotic have so many side effects, like EPS, tardive dyskinesia, sedation, orthostatic hypotension, and the risk. And if we are talking about second generation antipsychotic, it has lower risk of EPS and lower risk of tardive dyskinesia. But the main problem with second generation, I'm going to talk about that, is metabolic disorder. In particular, like first generation antipsychotic, we divide it into, again, like a high potency and first generation antipsychotic, moderate potency, and lower potency. So as I said, that high potency antipsychotic, we dose in 1 to 10s of milligrams, and low potency, we dose in hundreds of milligrams. High potency has more side effects like EPS, or if we talk about EPS, it has also it has high EPS side effects like tardive dyskinesia or ataxia, and in contrast to that, low potency antipsychotic has more anticholinergic side effects like sedation, orthostatic hypotension, and so those are the main side effects. So, and if in general, these are the main side effects, but all antipsychotic have additional side effects like slow thinking and sexual dysfunction. I would like to talk a little bit more about EPS, that's extrapyramidal side effects. Under that, there are 4 main types of EPS, like Parkinsonism, that in this disorder or in this side effect, patient experience Parkinson's-like symptoms, like they have rigidity, tremors, bradykinesia. Those are the main one, and the treatment for that is mainly anticholinergic, such as diphenhydramine, Benadryl, or benzotropine are the main one. And the second one is acute dystonia, in which patients feel rigid muscles of neck, mouth, or like the other body parts. Again, the main treatment is anticholinergic like Benadryl and benzotropines. Ataxia is also the restlessness of the patient, and mainly we treat this side effect with the beta blockers. And if you're talking about beta blockers, propranolol and nadolol are the two main ones. We can also use benzodiazepine like diazepam to treat acute rigidness or like to calm patient down. The fourth main one is Tartar Dyskinesia, in which patient has like uncontrollable movement. Even like if they want to stop themselves, they cannot. And that could be the side effect of long-term antipsychotic use. For tardive dyskinesia, we have different options. Like we can, if we say we can decrease the dose, but if patient is stable and the symptoms are stable, we normally prefer not to decrease the dose. So what we can do, there are newer agents available. That's recently approved in 2017 by FDA, and it is called Ingrezza. Ingrezza, I am just forgetting name of that, the generic name. But those are the one. There are other treatment options available like tetrabenazine. But the main advantage between tetrabenazine to treat tardive dyskinesia is tetrabenazine is twice a day dosing, or sometimes patient has to go up to 3 times a day dosing. On the other hand,
excuse me, Dr. Shama, sorry for
yes.
interruption. Ma'am, our audience asking for the slideshow format of the presentation. Can you please make it in a slideshow?
In a slideshow? Okay.
Yes, so that it will be readable.
Can you see that?
Perfect.
Thank you so much, ma'am.
I'm
Thank you
sorry
so
about
much.
that. I did not realize
It's
that.
fine. Fine.
Okay.
That's
So
fine, ma'am.
okay, thank you so much. So I was talking about Ingrezza. So for that, the main advantage between tetrabenazine and Ingrezza is dosing frequency, because all these psychotic patients have hard time remembering to take medication, or they do not want to take medication. If the condition cannot be controlled by these medication, so I mean the last resort or the last option is that to switch to clozapine. Clozapine is mostly reserved for refractory or patient that has so many side effects with the regular antipsychotic. So, I mean, as I talk about the different side effects of all these first generation and first generation, mainly antipsychotic, one of the main one is NMS, that's neuroleptic malignant syndromes. It is very rare to have this syndrome, but it could be possible, and 1% of patients may experience this. And this is mainly due to the blockage of D2 receptor. In this neuroleptic malignant syndrome, patient may have like severe agitation, confusion, fever, and they have like high blood pressure, tachycardia, and extreme rigidity. So if a patient may develop NMS anytime. It is not necessary that you just started the medication and patient experience. Sometimes patient is taking for many months or years, and they may develop neuroleptic malignant syndrome. So the treatment option that's available for neuroleptic malignant syndrome, that is NMS, is to discontinue the antipsychotic immediately, and then give supportive care. Like if patient have fever, like use cold blanket, or like Tylenol, or like give IV fluids. In some cases, patient may require other treatment, like the treatment option that's available is dantrolene, that's the main one, or sometimes bromocriptine. Those are the D2 agonists that help to calm down the receptor. Any questions so far? Okay, so this is just a journal overview of adverse effect of antipsychotics. So based on these symptoms, we have to decide that which antipsychotic is best for the patient. Like if patient is young and sexually active, then you have to, and if patient is complaining that they have to choose antipsychotic that may not affect, so then we have to come up with antipsychotic, and then like if patient has any previous history of seizures and so then of course we have to avoid agents that may increase that risk. If we are talking about sedation, we have to think about our elderly population, because they are already at risk for fall. So or if patient has history of Parkinson disease, we also have to think that we do not have to add agents that make worsen the symptoms. So, if we are now, those are the first generation antipsychotic. Now I'm going to talk about second generation antipsychotics. So all these are second generation antipsychotic. So like olanzapine, quetiapine, brexpiprazole, risperidone, clozapines, all these are second generation antipsychotic. And when we talk about antipsychotic, we mainly have to focus on I'm going to first talk about metabolic side effects. And if among all these antipsychotics, if we are going to categorize these agents based on their high risk, moderate risk, and low risk. So clozapine, olanzapine, quetiapine has the highest rate.
Doctor,
Yes.
your voice is not clear.
My voice
Yeah,
is
now
not clear.
Now it is clear. Now it is clear. Yeah.
Is clear? I think maybe I was going far. Okay, so can you hear me better now?
Yeah, very good.
Okay, thank you. So I was talking about metabolic side effects. And for all these antipsychotic, we categorize into three categories like high risk, moderate risk, and low risk. Clozapine, olanzapine, and quetiapine comes under high risk agents that may cause the most metabolic side effects like weight gain, dyslipidemia, or diabetes. So if patient have like history of diabetes, we have to keep in mind to avoid those agents. Under moderate risk, risperidone and paliperidone carries the moderate risk, and Erypropozole, ziprasidone, lurasidone, and asanapine has the lowest risk to cause any metabolic disorder. Another big one for this antipsychotic is EPS. So EPS, they also carry the risk for EPS, but quetiapine has the lowest risk to cause, and it is recommended in patients with Parkinson's disease who require antipsychotic. Clozapine, the big one is like agranulocytosis. So if I'm talking about agranulocytosis means a reduction in WBCs. So whenever so mostly clozapine is reserved for the patient who is not responding for other agents. And when doctor decides that, okay, patient has to start clozapine, then we have to monitor A1C, that's absolute neutrophil counts. They have to check at the baseline. And for the first 6 months, patient has to go for the blood work every 6 months, and then every 4 months for 1 year. Patient pharmacy, whoever is dispensing, and the patient has to enroll in the RAMS program. That's the general rule for the clozapine, that if there is no blood work, there is no drug. So if a patient comes to pharmacy or like facilities requesting to get a refill for clozapine, we have to check A1C first, and then we can refill the medication. If patient missed doses more than 48 hours, then doctor has to decide that we have to go back and start the titration back, or they have to continue the same dose. Then the next one is QT prolongation. QT prolongation is also a big one, and the highest risk is ziprasidone. So for example, if patient has any underlying cardiac issue and you want to decide that which antipsychotic is the best one, we should avoid quetiapine. Also, like I would like to mention here, increased prolactin levels. So prolactin is like the highest risk has risperidone and paliperidone. And the last one is seizures disorder. We just have to be careful. Clozapine has the highest risk to cause seizures disorder. Any questions so far? So as I was mentioning that about like all these metabolic disorders. So for second generation antipsychotic, we have to keep in mind that which one may cause the most metabolic effect, which one has the most EPS side effects, and clozapine is the big one for causing the seizures disorder, ziprasidone for QT prolongation, and prolactin level, risperidone and paliperidone are the worst one. So patient, I mean, it is very common if we talk about the therapy duration, it is very common that patient relapse more than 50% is not either like taking medication, or they have hard time because they already have this psychotic disorder and they have their hard moments. It is very hard for them to remember that they have to take medication. For that, like there are so many long-acting antipsychotics, second generations are available that doctors can initiate. Some are dosed every 2 weeks, some are dosed every month, and some are dosing every 3 months. But in order to start those, patients have to have like PO therapy initially, and then we can convert it to long-acting. That may increase adherence, and that may increase adherence. And I would say that some they have to be, if we decide that they have to stop antipsychotic, then they have to be symptoms free for 2 years. And those with a history of multiple disorders should probably be symptoms free for 5 years before continuation. So now, in order to understand better, I have few case studies, and we can understand better. So the first case is a 25-year-old man, BMI 35 kilogram per 35, and was recently diagnosed a diagnosis of schizophrenia. Here we have to the first point I'm going to like highlight that this patient BMI is 35. He often hears voice telling him that he's stupid and worthless and that he should just jump off his apartment building. So he has all those delusions. His parents become very concerned about his isolative behavior and brought him to the hospital. He was giving Haldol in the psychiatry unit, and now patients now present with neck stiffness and oculogyric crisis. Until now, he has not taken medication because he felt that he could control his symptoms on his own with vitamin and energy drinks. Though he was difficulty remembering to take these, he has an additional history of marijuana and alcohol use disorder. So which is most appropriate for this patient's symptoms at this time? Our options are benzotropine, number 2, dantrolene, number C, lorazepam, and number D, propranolol. I'm not sure you guys are going to participate or not, but Dr. Kamran, what do you think about that? Do I take feedback from the audience or just go and start talking about the options I have? Hello? Okay, so the best answer for this is we have option for benzotropine, dantrolene, lorazepam, and propanol. The best option, the best answer or treatment is benzotropine. Because if you see that patient has now presenting with neck stiffness. So here we are talking about acute dystonia. And for acute dystonia, as I said, that the best treatment option is either Benadryl or anticholinergic. Benzotropine is anticholinergic. We can go for lorazepam, but anticholinergic has better efficacy to relieve those symptoms. Dantrolene is the option B. Dantrolene is used for patients with neuroleptic NMS. So B is not the right answer, and the option D for propranolol. Propranolol is mainly used if patient has ataxia. So ataxia, I'm not seeing that this patient is not showing any signs of like inner restlessness. It clearly shows here that patient has neck stiffness. That's the sign of dystonia. And benzotropine, that's anticholinergic, is the best treatment option for this patient. Now, the second question is, he is initiated on Erypropozole. Which is the best rationale for this selection? Option A is Erypropozole has minimal risk of causing EPS. Number 2 is available in a long-acting injection to increase adherence. C, Erypropozole would decrease this patient negative symptoms. And the option D is Erypropozole is only dosed once daily. So option B is the right answer because it was mentioned here that he has hard time remembering to take his medication. So the goal is like to start antipsychotic, and after 3 to 4 months, so we can switch to long-acting antipsychotic to increase his adherence. Option A is not right because although Erypropozole has not as high EPS side effects, but still all antipsychotic carry the risk of EPS. And as you can see, like on the first slide, I mentioned there that Erypropozole, second generation antipsychotic, may or may not be effective for negative symptoms. And option C is only dosed once daily. I mean, that's kind of right, but the best option is option B, that this patient has hard time, the patient is not adherence, and if we are going to initiate or switch to long-acting one, that's the best option for this patient. Third question is, what is the best example of an adverse effect of Erypropozole that would be concerned when initiated in this patient? Option A, sedation. Number B, anticholinergic effect. Number C, ataxia. Number D, QTC prolongation. So I would say the best answer is, what do you think? Ataxia is the best answer because among second. Hello?
Yes, doctor.
Okay, you guys are there.
Yeah, they are answering in the chat box.
Oh, they are answering
they agree. Yeah, they agree with your answer. Yeah.
Okay, thank you so much. I did not see that. So the case number 4 is 1 year later, he no longer responds to Erypropozole, Abilify, and you decide to change his medication. He is only interested in oral medication. Given this patient history, which agent is most appropriate at this time? Options are clozapine, fluphenazine, olanzapine, and ziprasidone. The best option is ziprasidone. Option A is not correct. Option A is not correct because clozapine is mainly reserved for patient who is not responding to another antipsychotic. I mean, from this case study, we can see that the patient is responding. So I would not go with clozapine. Fluphenazine and
क्या पढ़ा रही है
olanzapine has option C is definitely do not go with
कपड़े क्यों नहीं मिलते
because olanzapine has the worst or the highest
गड़बड़
risk
क्यों नहीं है
of
कपड़े
highest risk of metabolic side effects. And as we can see that patient BMI
Participants,
is
can you
greater than
please
35.
mute your mics? It is requested to the participants that please mute your mics.
Fluphenazine, option B, fluphenazine is first generation antipsychotic. So I would definitely would like to stay away from that because the patient already has episode of acute dystonia with the previous antipsychotics. Any questions so far? So now I'm going to move for the next topic. Antipsychotic is over. You just have to keep in mind typical and atypical antipsychotic, their side effects, which one has the most TPS, which one has the least TPS among second generation. You just have to keep in mind for any metabolic and all those side effects, mainly the metabolic one, which one has the highest Ssris side effects, the QT prolongation, and which can increase the prolactin levels the most. So those are the main ones. Just focus on that because most of the case studies you are going to find, like they will talk about those agents. The next topic is depression. Depression is depression like MDD, major depressive disorder, or depression is one of the most common health condition in the world. Like people who are suffering with depression, they feel that they are hopeless. They have constant worry of something, that okay, something is going to happen, something bad going to happen, or they have like poor concentration, they have lack of energy, and they cannot sleep. Or in the worst case scenario with severe depression, they have like a patient has suicidal ideations, they want to die. So when you go to doctor, and like most of the time when you say that, oh, I am feeling like sad, or I am feeling like I do not have energy, then the next question most of the time doctor asks you, okay, have you ever thought harming yourself? And based on that, yes or no, they can decide that, okay, like, yes, you have major depression or like clinical depression, or like you have like very severe depression. So like for DSM-5, a patient have to have patient have at least 5 of the following symptoms almost every day for at least 2 weeks. And I said that like depressed mood or anhedonia. Anhedonia means things that gives you pleasure. You do not feel anymore like pleasure with those activities. For example, if you go for cycling and you feel that, oh, I don't want to go, that not going to give me anything. So those are the signs of depression. Additional symptoms include, as I said, like sleep disturbance changes, and those symptoms have to have like at least 5 of those for at least 2 weeks. So there is no test available to assess this patient. There is no like lab test that you can go and like give your blood or urine sample and say that, hey, and you can detect that, oh, you have deficiency of those neurotransmitter and you have depression symptoms. These are all like schizophrenia, depression. Doctors has to talk with their patient, and based on their symptoms, based on their responses, doctor has to decide either they have depression or like whatever mental illness they have. So once we diagnose based on like I can go here. So these are, as I said, that these are all like there is no test available. These are the major this imbalance of neurotransmitters doctor has to go, and there are these are There is an assessment scale. That's the most one I have seen here in US, like DSM-5 or like PHQ-9. So those are the questionnaire. Those are 25 questions, and if patient is score like 23 or over, that's the category of severe depression. When we diagnose depression, like we also have to rule out like if patient does not have any underlying condition. And the main one for any medical, if patient has thyroid disorder, that may cause depression-like symptoms, any vitamin deficiency, if patient is deficient in vitamins, and complain that, oh, I have lack of energy, I am tired. So those things we have to rule out. There are tests available, like if patient have B12 deficiency, we can say that, or iron deficiency, we can rule out those with the blood test. There are other medication or substances that may cause those type of symptoms, like the big one is like interferons. Those are those we use for the treatments of hepatitis, benzodiazepine, and alcohol, of course. And the next main one is beta blockers that may also cause depression-like symptoms. So if we talk about therapeutic options, we have psychotherapy, like we just have to talk like counseling type of thing. So counseling is very helpful if patient have mild to moderate cases. But like for more severe symptoms, like and we want to see more rapid response, then we have to go for pharmacotherapy. Those are available. And in the refractory depression or in very severe cases, patient has to go for electroconvulsive therapy. Psychotherapy combined with pharmacotherapy is recommended for moderate to severe depression. So there are different treatment options available. So the main one are first line, according to guideline, the first line treatment is SSRI and SNRIs. There are also bupropion and Merthazapine. Those are the good options. The other treatment options that's available is Tricyclic Antidepressant, monoamine oxidase inhibitors, but those two, like that, in practice, you do not see tricyclic antidepressant or monoamine oxidase inhibitors very often in the practice. I would say that monoamine oxidase inhibitor I have not seen. I have hardly seen 3 or 4 patients on monoamine oxidase because it has so many side effects. So the first one I'm going to talk is the selective serotonin reuptake inhibitor. Those are called SSRIs, is the first line agent. We just have to know about which one is SSRI, and the next one when I'm going to talk is SNRIs. So under fluoxetine, sertraline, paroxetine, citalopram, and escitalopram, and fluoxamine comes under SSRIs. And when among all these antidepressants, they are equally efficacious. It is just a matter of which one is the best for the patient. Like, as I said, for the atypical and typical antipsychotic. So if we talk about second generation antipsychotic, we just have to see which one is the best. Same is applying on SSRIs. Fluoxetine and sertraline is the most activating one. So if patient comes to you and complain that, okay, I do not have any energy, I do not feel like doing anything, so fluoxetine and sertraline is the best one. If patients complain that, okay, I have hard time sleeping, I cannot sleep, then paroxetine is the most sedative one, and you can prescribe this medication to your patient, and patient can take this medication at bedtime. That may help for depression as well as for sleep disorder. Trazodone doesn't come under SSRI, but if we are talking about most sedative agents, Trazodone is the best one. So in lower doses, Trazodone is used for insomnia. But if we go for like 200 or 300, the maximum is 400 milligram per day. Trazodone is used as an antidepressant agent. I would also like to mention that for fluoxetine and sertraline, that's the most activating one. If patient is going to take at night, that may not help to sleep. So the best time to take this medication is in the morning. So these are the main points you have to keep in mind, that when and which SSRI is the best for the patient. The next one I would just like to mention here that like the side effects for all these antidepressant is like GI complaint. Patient has nausea, vomiting, insomnia, like restlessness, headache, and sexual dysfunction is also a big one. So if your patient is like young and sexually active, and they have all these sexual dysfunction, then it is better. I mean, you can add bupropion for the treatment of it. It may help to improve the depression symptoms as well as the sexual dysfunction they may experience with all these SSRIs. I would also say that for Viagra, that's the sildenafil, may be beneficial for men. So instead, bupropion, if they do not want to take bupropion, they can take like as needed sildenafil to cope those symptoms. And then the next big one is serotonin syndrome. Then serotonin syndrome is the hypertension crisis. Patient may have, like if patient have drug interaction, they may experience serotonin syndromes, that high blood pressure. This is almost same as NMS, that's neurolaptic malignant syndrome, that patient has high fever, rigidity, and rigidity, restlessness. You just have to differentiate patient has based on the agent and symptoms. You just have to differentiate that the patient has serotonin syndrome or neurolaptic malignant syndrome. And then the best option, the best treatment is to reduce the dose and either reduce the dose or stop the dose based on the patient's symptoms. If you are talking about all these SSRIs, fluoxetine has the longest half-life. So you just have to keep in mind that fluoxetine has the highest half-life. And if we have to like switch to any other antipsychotic, you have to wait a little bit more to taper the dose. The next one is also the main point is QT prolongation. Citalopram has the highest risk of for the QT prolongation, and it is mainly happen for if we go over dose of 40 milligram. So the max is 40 milligram per day. In your practice, you will see max 40 milligram per day, but sometime you may see not very often 60 milligram or 50 milligram per day. In that case, you have to screen what other medication patient has been taking. And based on that, you have to either let the patient know that, okay, this is risk versus benefit, and you have to keep monitoring your symptoms. Also, like it may increase the risk of bleeding, hyponatremia, bone fracture are also the main big effects. If I'm talking about bone fracture, you have to keep in mind if your patient is elderly population, already have high risk for fall. So just like you have to let the patient know that, okay, you have to be careful because it may increase your fracture risk. And electrolyte, of course, hyponatremia is the big one. Then the next one is SNRIs. SNRIs in this category, we mainly have venlafaxine and diloxatine. Venlafaxine, we just have to keep in mind that, okay, I think I'm going very slowly. Venlafaxine, we just have to keep in mind that a patient who has high blood pressure cannot go over 150, and it may have so many withdrawal. I mean, we cannot discontinue venlafaxine, especially because it has withdrawal effects. Diloxatine is SNRI and is mainly like the other indication diloxatine has is diabetic peripheral neuropathy. If patient has diabetes and have nerve pain, you can give and has depression, so diloxatine is the best option. But also keep in mind that diloxatine is CYP2D6 inhibitor. So if patient is on medication that's the CYP2D6 substrate, keep in mind that if we are discontinuing diloxatine, you have to adjust the dose for CYP2D6 substrate. It may cause liver toxicity. The next one is Levo Sinapran. I mean, that's the hard name. The brand name is Fedzima. You do not see that in practice very often. It is not mainly approved for depression. It is mainly for it is approved for fibromyalgia. And this medication is very expensive, very fancy. Not going to see that in your practice. Also, it has to be dosed renally. So if patient has any renal insufficiency, it has to be adjusted, and creatinine clearance less than 30 milligrams, this medication is contraindicated. So as I said, the tricyclic antidepressant, it has main one for tricyclic antidepressant is it has anticholinergic side effects like sedation, orthostatic hypotension, and cardiotoxicity. TCAs also can be used for nerve pain or migraine pain or anxiety disorder, but in order to treat depression, SSRI and SNRI is the first line treatment. Monoamine oxidase is also you are not going to see in your practice, it has so many drug-drug interaction. If patient is on monoamine oxidase inhibitor, they have to avoid certain food like high in tyramine, like cheese, preserved meat. If you decide that, okay, if a patient has to switch to monoamine oxidase, and patient is on SSRI and SNRI, it has to has 2-week wash out period. It means that patient med has to completely wash out from the body, then you can start, otherwise patient may have hypertensive crisis. Salicyline is monoamine oxidase inhibitor that is available in a patch form. So if patient has hard time, elderly population, for example, if they have hard time swallowing medication, that's the best option. Yeah, those are the main ones. Then just keep in mind that it has to have 2 weeks washout period, and then avoid certain food like cheese. They cannot eat cheese. Okay, so serotonin syndrome, I already talked about that this is a hypertensive crisis. Patient have hyperactivity, rigidity, tremor, agitation, diaphoresis, hypothermia, and the treatment is just to discontinue agent. Supportive care for if they have muscle rigidity, you can use any benzos like clonazepam is a big one. You can use it. If they have seizures, you can use anticonvulsant like Keppra. That's levetiracetam or Lamictal, and aspirin for hyperthermia is has the best evidence to treat this syndrome. Bupropion, as I said, that this is an add-on if patient has any sexual disorder. Bupropion can also be used for smoking cessation, but the dose is different. For smoking cessation, normally it is 150 milligram With propion, you also have to keep in mind for seizure disorder, you cannot go over 450 milligram per day. That's the big one. And you have to slowly titrate the dose up. You cannot just like rapidly increase the dose. Trazodone, as I said, that trazodone is also a good one if patient have insomnia in low doses. So you can use this for insomnia, and for the higher dose, you can use as an antidepressant. This is mostly like you can use with SSRIs if patient is not responding or not have adequate response with SSRIs or SNRIs. Trazodone would be a good option. Merthazapine is another antidepressant. The side effect that is beneficial for the patient is increased appetite and weight gain. So if you have elderly, frail patient who has hard time, who is losing weight and has not good appetite, merthazapine is also a good one. So merthazapine for appetite and weight gain, and trazodone for insomnia. Those are the big one. When you start the patient on antidepressant, you have to let the patient know that in order to see full benefits, uh, it takes about 4 weeks, and then like they have to continue this medication up to 12 weeks. So once they have symptoms in control, continue for additional 4 to 9 months. And also have to let the patient know that if they have any thought, they may have like nausea, vomiting, and upset stomach, and they may see like if they are expecting that the symptom is going to improve in 1 or 2 days, is not going to happen. And like if they start medication and they have suicidal thinking, they have to let the doctor know, because in that case, that's a black box warning, and they have to discontinue the medication or change to another SSRIs or SNRIs. So for combination therapy, like you can use like SSRIs plus trazodone, depending on patient symptoms. Like this combination, you have to come up based on patient history, like what you have to add, or like which one is the best combination for the patient. For a refractory antidepressant, you can use second generation antipsychotic, or like to improve the symptoms. And the best one that has the evidence is Abilify, Erypropozole, Brexpiprazole, XLT, and quetiapine, extended release. I have seen the patient is on not only extended release, they may take like the regular tablets, olanzapine plus fluoxetine for the resistant depression. There is some evidence for ketamine, but I have not seen in my practice, or you will not see in your, I don't know, like over there, but I have not seen ketamine very often, but there are few evidence available. Other agents, those are available is lithium, levothyroxine, modafinil, and scopolamine. So here I would like to mention scopolamine. There are evidences available that scopolamine is like you can augment treatment with scopolamine, but in my practice, I have not seen scopolamine for depression symptoms. Mainly, the main one I have seen is like SSRIs, trazodone, bupropion, Abilify, or olanzapine. So again, I'm going to talk about this one. I'm going to just discuss about case number 5 and 6, and then we move to the next topic, because it's already 55 minutes. A 45 years old woman has a medical history significant for sleep apnea, hypertension, type 2 diabetes, chronic pain, and bulimia. She's in clinic today for an assessment of her depressive symptoms and a medication evaluation. She endorses a sad mood. So that's the sign of depression. Poor appetite, another one. Weight loss. poor concentration and feeling of hopelessness and worthlessness. So she has all those symptoms that we talked about. For the past 3 weeks. She has also stopped going to her book club because she is not motivated to get out of the house, and she has frequent nocturnal awakening. She denies suicidal or homicidal ideation. She denies any use of alcohol, tobacco, or illicit drug. So that tells you that she doesn't have like any underlying condition. She currently takes hydrochlorothiazide, that's a blood pressure metformin for diabetes, hydrocodone acetaminophen, that's the Norco for pain, and aspirin. Aspirin could be like, it's 45 years old. I would say that aspirin dose is not mentioned here, but if she's taking 81 milligram, that could be prophylaxis for heart, baby aspirin. Her current BMI is 20, BMI is normal, and her blood pressure today is 152/94. Blood pressure is a little bit high, but I would say that maybe it is because of anxiety, she's worried, or sometimes patients have high blood pressure when they go to doctor's office. She reports adherence to her current medication. So she does not have any issues of taking her medication. So which selective serotonin reuptake inhibitor would most likely interact with her current medication? So which one is the best answer? So here we have to keep in mind that what medication she is taking and which one can interact. So options are citalopram, fluvoxamine, paroxetine, and sertraline. So what is the best answer for this medication? The correct answer is paroxetine. And the reason for that is paroxetine is CYP2D6 inhibitor, and it is going to interact with the hydrocodone acetaminophen. Option B, fluvoxamine is CYP A12, so that's not going to interact with any of her medication. Citalopram is option A and D, citalopram and sertraline. They do not have much interaction with any of those medication. Question number 6, which antidepressant would be most appropriate for her depressive symptoms? Options are bupropion, fluoxetine, Merthazapine, and venlafaxine. So the best answer is Merthazapine. As I said that like this, you have to think what symptoms she has. She's losing weight. So she's losing weight. She has poor appetite. So Merthazapine is the best option for her, because in that case it will increase the appetite. Bupropion is has some side effect of some weight loss, so that's not the best option for her. And fluoxetine, as I said earlier, that fluoxetine is the most activating one. So if she has already insomnia and we are going to give her activating SSRI, that would worsen the condition. I will go for one more question, then we will move to the bipolar disorder. It has been 4 weeks since her initial visit with you, and she has been treating with citalopram 20 milligram per day in the morning. She is still present with sad mood, but her insomnia, concentration, and appetite have improved. She still has feelings of hopeless and worthlessness, lack of motivation, and anhedonia. She has no adverse effect at this point, which is the best recommendation to optimize her therapy. So the best answer is like increase the current dose to 40 milligram, because you see that with 20 milligram, she has improvement in mood, concentration, and insomnia. So it means that it is working, but it is not get to the point, its maximum therapeutic level. So the best answer is to increase 40 milligram per day, and the maximum dose for citalopram per day is 40. We do not want to continue at option A is not right, because we do not want to continue 20 milligram per day, because she has some improvement, but not full recovery. Add Erypropozole, we are not going to add anything at this point because it is working. Again, the option D, change to different SSRIs, we would not change at this point to different SSRI because her symptoms are improving. Any questions so far? Okay, so the next psychiatric disorder is bipolar disorder. Bipolar disorder is again a mood disorder in which moods can fluctuate from extremely sad or hopeless state of depression to an abnormally overexcited or irritable mood called mania or hypomania. So each mood episode represents a drastic change. So they have completely that they are so at some point they are in completely manic state in which they are excited, they are doing everything. And in bipolar 2, that's a major depressive episode. They have completely hopeless, not willing to get out of the bed or house. And bipolar disorder, particularly type 2 bipolar disorder, is often misdiagnosed as a major depression. That diagnosis is important because the two conditions are treated differently. And if we talk about the symptoms, patient have to have at least 4 episodes of mania or depression in 1 year. So these are the treatment options. The main one for bipolar disease is lithium. Lithium is the gold standard for treating bipolar disorder, mainly manic disorder. And here we can see that like any other antipsychotic or antidepressant, there are also other treatment options available. Like for mood stabilization, you can see carbamazepine, Lamictal, or Depakote. That's the divalproic acid, carbamazepine, and lamotrigine is the. So these are the generic names. I'm sorry, I'm taking brand names. Those are different than your brand name, but mainly I'm trying to talk in generic. So antipsychotics, all antipsychotic can be used to treat bipolar disorder except brexpiprazole, clozapine, and erypropozole. If we talk about also treatment option, benzodiazepine, mainly lorazepam or diazepam, can also be used for acute agitation, because when they are in manic state, we have to calm them down. And the best one is lorazepam and diazepam. We can, so in general, we talk about antipsychotic and which one we can. So just keep in mind that which antipsychotic we cannot use. Those are the 3 ones: brexpiprazole, clozapine, and erypropozole. And which benzos can be used, lorazepam or diazepam. So those are the 1. So if we talk about lithium, lithium has half-life of 20 to 24 hours. It takes about 5 days to get to the steady state. And mostly the initial dose is somewhere between 300 to 600 and not up to 900 milligram per day. When you start lithium, you also have to keep in mind for the therapeutic level or the for lithium, because increase in lithium concentration in blood may cause toxicity. When we start for monitoring parameters, we have to check CBC, electrolytes, renal function. Renal function is the big one. Electrolyte is, all these are the big one. Thyroid function, EKG, and pregnancy test. So if you have a young female and has bipolar, lithium is not the good option, because this agent is listed under teratogenic. So it means that it may cause birth defect. And patient have an And if patient has no other options, then patient is young, they have to check pregnancy test every 3, 4, 5 months or every 6 to 12 months. Lithium toxicity can be seen with levels of 1.5, and the symptoms are lethargy, tremor, confusion, seizures, and coma may even lead to death. So if patient has started like lithium and comes to your pharmacy or comes to you, has like tremor, confusion, and like then you immediately have to go and check their lithium levels. Okay, so I would go over quickly for case number 9. A 26-year-old man with a history of type 1 bipolar disorder present to the patient's unit. His wife found that he was withdrawing from their life saving from the bank. He states that he's perfect candidate for the presidency. He's hyperverbal, so that's you have to notice that, and has not slept in the past 48 hours. He's placed on a 72-hour hold for control of his manic symptoms. He has a history of non-adherence to medication. So that's the big point, 248. He was not slept for past 48 hours and currently takes none. Last hospitalization was 2 months ago when he had significant depressive symptoms and suicidal ideation. He has 3 or 4 hospitalizations per year, and his history of medication trials include olanzapine and Lamictal. He has also received a diagnosis of hepatitis C with an AST of 175 and ALT of 186. So question is, which mood stabilizer is most appropriate for this patient at this time? Options are carbamazepine, Depakote, Lamictal, and number 3 is, hello? Hello? Can you hear me? Okay, so and the D option is lithium. So option number D, lithium, is the best answer because lithium is, patient is in manic state. You can see that hyperverbal, not slept in the past 48 hours. So that's the big one. Carbamazepine is effective for maintenance treatment, but considered second or third line for acute manic episode. Depakote is also good for maintenance treatment, but this patient has hepatitis C, has a liver disease, so this is not a good option for this patient. I'm just going to, you can see that in question 10 and 11, patient is presenting with the emergency room and has, so you can go over with this. Question number 11 is also a big one because if patient is on lithium and is going to start ibuprofen or NSAIDs, that may cause lithium toxicity. To always keep in mind what OTC medication patient is starting or taking whenever you are taking patient history. And this is a very good case. If patient comes to you or is starting a lithium, always keep in mind that you have to check OTC meds. And again, I'm going to skip that. The next topic is anxiety. For antidepressant or anxiety medication, you just have to keep in mind that which agents can be used for GAD, generalized anxiety disorder, OCD, or PTSD. So which one is the first line agent and which one you can use to immediately to calm the patient down. For this, there are also other agents available like Buspar. Buspar is the big one. You can see in anxiety disorder, pregabalin, sometime to keep the patient down. Antipsychotic, again, for PTSD, you can use Prolongation, anticonvulsant, and atypical antipsychotic. For here, I'm just going to discuss these case studies. So the next case is a recent Iraq war veteran has been treated successfully with paroxetine for his major depression for the past 3 weeks. He presented to the clinic experiencing nightmares, feeling on edge all the time, and having flashbacks of his time in the war. He is evaluated and given a diagnosis of post-traumatic stress disorder, that is PTSD. He has no history of substance dependence and no significant medical history. Which recommendation is most appropriate for this patient at this time? So patient is already on paroxetine, successfully treated, but still he has like all those flashbacks. So option A is continue paroxetine because it treats both PTSD and major depressive disorder. Option B, discontinue paroxetine and initiate sertraline, which treats both PTSD and major depression. Continue paroxetine and lorazepam for the anxiety symptoms, and D, discontinue paroxetine and initiate buspirone for the anxiety symptoms. So in that case, option A is the right answer because paroxetine should be continued at this time. We can see that patient has been successfully treated with paroxetine and is considered a first-line agent for PTSD. You can treat patient. Option B is not right because discontinue paroxetine is not the right option because patient has patient has a successful story with paroxetine, so we are not going to discontinue paroxetine. Option C, you can just say that discontinue paroxetine, add lorazepam. You cannot do that because again, paroxetine patient is good with paroxetine, and adding lorazepam is not a good idea. If patient has episode for anxiety symptom like acute anxiety panic attacks, you can use lorazepam, but not in this case. The next one, I'm not going to discuss this one. So just go to insomnia. Because how many minutes do I have, Dr. Rana?
But 10 minutes because we have to take the Q&A session.
Okay, I will try to finish in next 10 minutes. Okay,
Yes.
so okay, so then insomnia is the next one. Insomnia is just like inability to initiate or maintain sleep, because few patients they may take hours to fall asleep, or if they sleep they can wake up like in an hour or so. So that's if patient have those type of symptoms, then it means that they have episode of insomnia. So type of insomnia, like as I said, transient insomnia, if patient has acute stress. Short-term insomnia is like, again, that's if something is going on and patient is not able to sleep, that's called short-term insomnia. And chronic insomnia is like rule out any other underlying medical condition or psychiatric cause. So the treatment option that's available is benzodiazepine, non-benzodiazepine, and others. So if benzodiazepine is not a first-line agent because it has so many side effects, and it has if we are talking about side effects, it has I would say that number one is addiction. It is very hard to taper benzodiazepine. It has residual daytime sleepiness because the half-life is long. So patients still have hangover effect. Rebound insomnia is the big one. And retrograde amnesia, it means that losing memory for a short period of time. And I said that it has like residual daytime sedation, so it's not a good option for elderly population. So all PAMs like lorazepam, alprazolam, trizolam, temazepam, so all comes under benzodiazepine. If we have no option, like if we must have to like initiate benzodiazepine, lorazepam, oxazepam, and temazepam are the big one, or trizolam. Those are mainly for the sleep disorder. For under non-benzodiazepines, those are the good options. But we also just have to keep in mind that Ramelteon and zolpidem. So if patient has sleep apnea, that's another disorder. So you have to avoid these two agents in a patient with sleep apnea. And we already discussed about trazodone. Trazodone is a good option in low dose, like 50 milligram or 25 milligrams at bedtime. Another, like the other options that are available are diphenhydramine, that's the Benadryl, doxylamine. Those are available as OTC, and those are the good options. But the side effects of this is daytime sedation or the grogginess. Patients still have residual daytime sedation, and is not a good option for elderly population because of the anticholinergic side effects. Okay, so the next case is, I'm just going to discuss one case and then move to the next topic. 38-year-old kindergartner teacher present to the clinic today with noticeable dark circle. Dark circle tells you that she's not sleeping at night under the eyes. She has difficulty with sleep, mainly with staying asleep. It takes her about 20 minutes to fall asleep, but after about 2 hours, she wakes up and cannot fall asleep again for several hours. This pattern has taken a role on her job, and she feels tired all the time. She once took diphenhydramine for sleep, but had to miss work because of extreme drowsiness in the morning. She wonders whether she can take any other medication. Her other medical problem include hypothyroidism. For that, levothyroxine 125 microgram at bedtime. Hypertension, hydrochlorothiazide 25 milligram in the morning, chronic back pain, ibuprofen 800 milligram 3 times a day, and major depressive disorders, and she takes citalopram 20 milligram in the morning. So our options are which agent is most likely contributing to her insomnia. Options are citalopram, hydrochlorothiazide, ibuprofen, and levothyroxine. So the right answer is option D, levothyroxine, because she takes at bedtime. So levothyroxine, if you see in your practice, this most of the time, like in 99%, levothyroxine is recommended to take in the morning, first thing in the morning on empty stomach. But she takes at night, so we have to move levothyroxine instead of bedtime, she has to take in the morning. Option is not right because she's already taking citalopram 20 milligram in the morning. If she takes at night, we would say that, okay, that may cause insomnia. Hydrochlorothiazide and ibuprofen doesn't have to do anything with that. Those agents does not have any side effects of causing insomnia. So then the next one is alcohol abuse. Alcohol is the most common abuser used. It is a CNS depressant.
Excuse you, ma'am.
Yes.
Ma'am, we have only a couple of minutes left, so we can we take the question answers of the participants, because
hi, Dr. Rida. Just 3 slides are left. I think so. Let her finish first. She will finish within 5 to 7 minutes.
Sir. Sure, sir.
Answer she can give us separately. We will provide it to the WhatsApp group.
Okay. So okay, I'm going to just finish. Yeah, thank you so much. So alcohol abuse, alcohol is the most common one. You can find so many abuser. So the best treatment available for alcohol abuse is disulfiram. And the next one, you can treat with lorazepam preferred in liver disease, diazepam with history of seizures. I'm going to just go to the case study. Okay, so a 50-year-old patient with a 25-year history of alcohol dependence, 25-year history. So point to be noted, was found unconscious after his last drinking binge. He was first admitted to the medical unit for alcohol withdrawal symptoms before being transferred to the substance dependence unit. His last drink was 6 hours ago and fluid has been initiated. He has had 3 alcohol withdrawal seizures in the past and an episode of delirium treatments. He also has significant hepatitis and liver function test shows AST of 220, ALT of 200. Additional laboratory test value include albumin 4.2, alkaline phosphate 112, total bilirubin 0.5 milligram, prothrombin time 1 second, platelets and creatinine clearance 72 ml per minute. So question number 20 is, which symptoms are you most likely to observe in the medical unit in this patient? Option A is alcohol craving, number B, delirium treatment, number C, increased heart failure, and number D, it's seizures. So answer number 20, the answer is C. The right answer is answer number C, increased heart rate. Which agent is the best for his alcohol withdrawal treatment? Question number 21. Number 21, the right answer is diazepam. I'm going to go over to opioid dependence. Opioid disorder, there are also if patient, all these are the short-acting opioids and the long-acting opioids. If it mainly opioids are used to treat pain, like hydromorphone, oxycodone, Percocet. Percocet is a combination of acetaminophen or hydrocodone. But once patient is taking, it has plus and minus. If these medication is very good to treat pain, but the side effect is the addiction. If you take this medication for a long period of time, it is very hard to taper down the patients, and some patients also abuse it. So if patient has hard time, or for example, if patient has addiction, so you have to treat the patient. And the most common agent that is available, common treatment option that's available is methadone. So here you have to keep in mind that methadone, if you are treating pain, it has in very low doses. Like you can go up to 15 milligram per day, like 5 milligram once a day, or 5 milligram twice a day, or 5 milligram up to 3 times a day. But if you see methadone, like a high dose of methadone, like 40 milligram per day or 50, or go up to 80 milligrams, then it means that the patient has opioid dependence, and this is the treatment, because methadone has a long half-life, so it stays in the body, and it helps to reduce all withdrawal effects. Another treatment option that is available, I would say that for the treatment of pain plus opioid dependency is bupropion, naloxone. That's also a good option. Sometimes you see this medication to treat pain, or sometimes you see that for opioid dependence. The next one is the next disorder is tobacco dependence. So smoking cessation is you just have to, it is very hard when patient is smoking to quit, but you just have to assist. And for that, for tobacco cessation, 5 A's is the big one. Like you just have to ask patient, advise, assist, check with patient if they are willing to quit smoking, or if they are not, advise that, hey, this is not good for your health condition, you have to start thinking about quitting. And then once they are willing, you have to just help them to make all those office visit to quit smoking. There are treatment options available. You just have to keep in mind like nicotine gum, lozenges, patches. Um, Most of the time in practice, you see gum, lozenges, and patch, but other formulations are also available like inhaler or nasal spray. Those are the fancy ones and it's very expensive. I mean, but I mean, if patient can afford, those are the good option instead of like chewing a gum or keeping lozenges in the mouth. And the next one is like bupropions. As I said, when we were discussing SSRIs, I'm sorry, antidepressant, bupropion is depending on dose, you can treat that as an antidepressant or like you can use this for smoking cessation. If you use that, you just have to pay attention about formulation and dose. And you can say that if you see that, okay, the indication is like 300 milligram once a day for smoking cessation, you have to question that prescription because the dose that normally uses 150 once a day. And the brand name is Zyban. And for the antidepressant, the brand name is Wellbutrin. So you just have to keep in mind for the formulation and the dose. Chantix Varenicline is also a good option for smoking cessation. You just have the same. You just have to assist your patient, which is the best choice. Varenicline has a specific dosing regimen. For day 1 to 3, patient has to go for 0.5 milligram once a day, then 4 to 7.5 milligram twice a day, and then day until the end of treatment, it has to be 1 milligram twice a day. So if you see again, if you see your patient, that patient is on like a day, 1 week has already passed and patient is still on 0.5 milligram. So then you have to question that no, in order to see maximum effects, patient has to be 1 milligram BID. With all that, like these is the just a summary of like everything like weight gain, which one may cause weight gain, weight loss, disulfide reaction. Those are this is a big thing, and you guys have to know for disulfide reaction that if patient takes, for example, here we mentioned metronidazole. So for example, if patient has infection and is taking metronidazole 500 milligram 3 times a day, you must have to let the patient know that, hey, while you are taking your metronidazole, you have to keep in mind, stay away from alcohol products. Like do not drink alcohol, even do not use any mouthwash or toothpaste that has alcohol. Disulfiram is a series of reactions. Patient have like, it has whole mechanism of action that it is going to inhibit alcohol dehydrogenase, and patient has nausea, vomiting, hangover effect. Is a very bad feeling like if patient has disulfide reaction. Keep in mind these medication, metronidazole, like sulfonylurea is also a big one because many patients, they are on diabetes like glyburide. Those are the sulfonylurea. So just keep in mind, these are the conflict point or the good points for case studies. QT prolongation, those you must have to know that which one may cause QT prolongation, hepatotoxicity, and which one may cause Ssris-like disorder. And the last slide is like inhibitors. So these are the big one because you have to know which one is a CYP2D6 inhibitor or which one is a CYP2D6 substrate. So for example, patient is on CYP2D6, if MET is a CYP2D6 substrate and is also on CYP2D6 inhibitors, so you do not supposed to use those two medications
Dr. Shama,
together. Yes.
sorry to
Okay, that's fine. That's fine. It's okay. Okay, guys, thank
Dr.
you so
Shama.
much. Yes.
We only have 30 seconds left, so I would like to say that we have to wind up the meeting, I guess.
Okay, no problem.
So
Yes.
thank you so much everyone to be with us in this informative session, and a very thanks to Dr. Shama for presenting us that much informative presentation, and also for giving us time through your very busy schedule.
My
Uh,
pleasure.
Thank you so much, ma'am, and thank you for the participants to being interactive with us throughout the session. We will meet you soon in the next class. Till then, take care and Allah Hafiz.
Allah Hafiz. Thank you so much. Thank you, Rida. Thank you, Rana, and all participants.